Before we get started, I want to remind everyone about CEUs. Completing the 5 evaluations is required to earn CEUs. Follow the links in the email you received about this seminar to complete the evaluations. And don't forget to visit our website, BIANJ.org, to view the poster presentations. These research posters are being presented by senior level students in healthcare. This workshop is Comprehensive Approach to Concussion and Athlete Brain Health. Our presenter is Dr. Matthew McCarthy. Dr. McCarthy is a board-certified pediatric neurologist and a fellowship-trained sports neurologist with expertise in managing acute concussion, post-concussion syndrome, and the entire spectrum of neurological conditions in athletes of all ages and competition levels. He is a member of the Summit Medical Group Department of Neurosciences and is based out of Florham Park, New Jersey. If you have any questions, enter them in the Q&A tab, which is at the bottom of the screen. They will be addressed during Q&A in the latter part of this workshop. This workshop will end promptly at 2:45.
Go ahead, Dr. McCarthy.
Yeah, is my screen shared?
No, sir, not yet.
There we go. Okay. Sharing now?
Yes, sir.
Okay. I'm Matt McCarthy. I'm going to be talking a little bit about sort of a comprehensive overview to the approach to concussion and overall athlete brain health. Really excited to be here with everyone, even if it's only able to do it virtually. So hopefully we can cover a lot of material. I'm trying to highlight a few things specifically to go into a little more depth, because obviously don't have enough time to cover everything in this, but make sure if there are questions, send them in throughout, and we can kind of save time for some Q&A at the end. So athlete brain health, I think it's important to define some things before we start. So this is sort of a person's life, and typically their sports career, when they're active in sports, when they're sort of at the most risk for sports-related injuries, including concussion, tends to be in the earlier portion of their life, usually sort of school age through high school and college is sort of the peak for that. And so as a pediatric neurologist, this is something that definitely covers a lot of the age range that I'm typically dealing with in pediatric neurology overall. But certainly concussion is occurring outside of that range too. But the first thing to define is concussion. So concussion is a temporary brain injury. It's a brain injury that should have a beginning and an end. It's caused by forces that lead to brain movement, and that should typically last days to weeks. So if you're looking at somebody's sports career, it's common for people to have 1 or 2 or 3 concussion injuries over the course of that career, but these should be self-limited events. Next term is post-concussion syndrome. This is another term that's commonly used. People usually use it just to describe sort of long-lasting concussion symptoms. But really, it defines the occurrence when symptoms continue after a concussion heals. So post-concussion, the concussion is now gone, syndrome, there are still symptoms there. These symptoms are caused by multiple interacting causes. And typically we think of these lasting from months to years, so longer lasting, but now caused by multiple interacting causes rather than the acute injury still being present. Finally, athlete brain health, long-term brain health. And I think one of the highlights that I want people to take away from this talk is that should really be the focus when we're seeing athletes, when we're seeing people with concern for brain injuries is not any specific injury, but what's the overall long-term brain health effect for that person? And that's both positive and negative. What are the risks? What are the benefits of the things that they're doing in their life right now? And really anytime we're seeing, I'm seeing people, I'm always looking through a lens of long-term brain health. What's the long-term impact of this? So just a little bit of an overview of what I'm going to talk about. First, talk a little bit about baseline testing. It's something that comes up commonly with concussion. So I'm going to talk about that, the idea of sort of collecting baseline information to use for helping diagnose and manage concussion, and talk a little bit about defining concussion and how we diagnose it, a little bit about acute concussion management, talk about post-concussion syndrome or PCS, how to diagnose and manage that, and finally at the end, some topics on long-term brain health. And as you see on this slide, I'm going to be coming back to sort of this to sort of mark our time throughout the talk, but that sort of lens of long-term brain health, anytime someone's coming in, whether it's for a baseline, because I'm treating PCS, because they're being managed for concussion, every single time I see them, I want to sort of have that long-term focus on all those patients. So starting with baseline testing, so it's something ideally you're collecting information before the person's going into sort of a sport or activity that they may have risk for concussion. And it's a great idea, gathering baseline information. So knowing something about the person when they're not injured that can potentially tell us something about how we can help in diagnosing, preventing, treating that person when they are injured. It's great in theory, but it's really difficult to figure out what the best approach to that is. People ask me all the time what the best baseline test is, and really the most important question I want those people to ask is, where would I go if I was going to be treated for a concussion? Because the information that you're collecting as a baseline, there's a ton of different objective tests out there. There's a lot of different approaches to doing it, but that baseline information needs to be useful to whoever the person is who's going to manage that concussion. So some people are comfortable with balance tests, some people like visual tracking tests, some people like neurocognitive tests, some people like history, comprehensive history and exam is the main part of it. But it has to be something that will be able to be interpreted correctly and be able to be used by the person who's going to treat you with a concussion when you go to them later. Ideally, though, it should sort of be based around a detailed neurological history and exam. And there shouldn't be any single test that we're relying on for diagnosing a concussion or determining when it's safe for somebody to return to play after concussion. That's something that sort of was happening frequently. But there's not really any single test for concussion that can definitively tell you yes or no, this person is or isn't concussed. It's all sort of taken into context. And so this is a paper that came out in 2018, pretty recently. I'm looking at some of the retest reliability of common concussion assessment tools. So this is from the NCAA and the Department of Defense CARE Consortium. So it's about 30 colleges and also all the military academies. They looked at a series of baseline evaluations that are being done in all their athletes and cadets. So this was the best for balance testing, neurocognitive tests like IMPACT or CogState, SCAT. They also used some other sideline cognitive assessments, King-Devic. There were a bunch of different tests, and they measured those beginning of each season and sort of had repeated measures over time. And they were looking at whether the measurements seemed to be stable, whether it was sort of consistent over time. And what they found from that takeaway from the first couple of years of the study was basically that almost all the measures fell well below any level of clinical utility in terms of how reliable they were. There were a couple that kind of approached the acceptable level, but none of them were really at a level where we should be using them clinically. And even the NCAA, their summary from this study was that the tools we're currently using for baseline assessment, for concussion assessment, don't meet the accepted reliability thresholds for clinical interpretation. That doesn't mean we shouldn't use them, doesn't mean we should throw them out, but it does mean that there's always a need to take those into context. They can be used as sort of helpful information, helpful supportive information, but none of them are steady enough measures that you can definitively say this is normal, this is abnormal in any individual. So my version of a baseline for neurologic visit is really focused on history and exam. So going through a comprehensive neurologic history. What are the potential recurrent symptoms that person has, any relevant comorbidities, any history of brain trauma or head trauma in the past, what their family history is, what medications they're on, and then a neurologic exam. So a general neurologic exam, but some focused concussion exam elements. And then supplementary tests, everybody will sort of have an area that they may feel comfortable using those tests. But it really needs to be individual to the actual person who's going to manage the concussion. Applications of that brain health baseline, it's not just to sort of take stuff in a drawer or sort of store it somewhere and never think about it again. There's really a lot of ways you can use that brain health baseline. Number one is just screening for undiagnosed or untreated neurological or psychiatric conditions. So I've done thousands and thousands of baselines, and the number of people I picked up with undiagnosed migraines, tension headaches, depression, anxiety, cervical issues, There's a lot of things that can be picked up, and those things can be actively managed and treated before it becomes a problem later. And so screening for those things in advance is always helpful. Second, it can help with your sideline evaluation of acute concussion. So knowing what that person was like, getting a snapshot of their brain function, how they're feeling, what they're usually like, knowing what their exam looks like can help you if you're seeing them and trying to figure out if there's anything changed from normal. Also can help confirm whether concussion is the correct diagnosis and help you guide the management return process, figuring out what other things might be contributing to the symptoms the person's feeling. Also, if you're doing it sort of serially every year, you can monitor for any ongoing problems and issues in the background, things that might be related to the sport that they're playing. And then one of the most important things is just ongoing concussion and brain health education. The amount that the information changes year to year is pretty significant. So if you go back 10 years, the things that we were telling athletes, the things that we were telling people about concussion is so much different than it is today. A lot of people, if they haven't been in to see somebody and only get kind of snippets here and there, news stories, they may not have a good sense of all the updated things that are going on. So maintaining a good ongoing education for your patients. So it's just an example from a high school I was working with. Essentially, this was from a football team. Basically, every player on the team, I had a list of all the exam findings on one side. On the other side, there was a list of all the history elements. And so if somebody, took a hit and there was a concern that they might have had a concussion, I could pull that out and look, okay, these are some of the things we noted on our baseline exam. Is that relevant in sort of helping determine what's going on right now? And I found that many times it can be really useful information in the moment. So that baseline information you collect before the season, once the season's done, in theory, at some point you're repeating it kind of over time to kind of keep getting updated new information. I think this is an important concept, but one that's still sort of evolving. We're still trying to figure out what the best way to do that is. So during a sports season, someone may get a concussion. So when when there's concern for concussion, it's a really difficult diagnosis to make. 3 reasons why concussion is such a difficult diagnosis to make. There's obviously a lot of reasons, but the 3 kind of top reasons to me. Number 1 is that we know that not all brain pathology or injuries cause a clinical effect. So from sort of all areas of neurology, we know that people can have a stroke, and it doesn't cause any clinical effects or a silent stroke. People can have a small tumor. People can have a small area of cortical malformation. It doesn't produce a clinical effect. We find it incidentally on imaging. So not every brain pathology is going to cause any clinical effect. For concussion, in order to diagnose it at this point, we're relying on that person presenting with a clinical syndrome. So there's sort of 2 thresholds that have to be met for somebody to be diagnosed with concussion. One is there needs to be an impact or a force that's significant enough that it sort of causes injury. So you have to cross that injury threshold. And then if that person has an injury, it has to be a significant enough injury that it crosses that person's symptom threshold to produce symptoms, so we kind of recognize it as a concussion. So this always is something that's interesting to talk about, because if somebody's getting diagnosed with lots of concussions, you have to ask, is that something that's related to an injury threshold where they're very easily getting injured, or is it something related to their symptom threshold, or even minor injuries causing significant amounts of symptoms in that person? And I always, the example of sort of somebody who's getting diagnosed with lots of concussions, every time they get hit, they're having symptoms or diagnosed with concussion. I'm actually less worried about that person as I am about another person who's getting hit over and over and over and over again and never reporting any symptoms, because that person's probably in the long run going to experience significantly more head impacts in the course of their life. And that in the long term is one of the things I'm more worried about, rather than just number of diagnosed concussions. It's really repetitive head impacts. Second reason that concussion is a really complicated diagnosis to make is that not every neurological clinical effect you see after someone takes a hit is due to concussion. So people can, if you look at sort of the list of potential concussion symptoms, there's a list of 20, 30 things. All those things can happen for other reasons, but all those can result from somebody taking a hard hit, being in an accident, having a fall, without that person being concussed. So it doesn't necessarily have to be coming from concussion. And then third, even if a person is concussed, when someone is concussed, some of the things they're feeling, some of the symptoms, might still be caused by other things. So just because you see somebody get hit, they're experiencing symptoms that are consistent with concussion, it doesn't mean that that's the only thing contributing to those symptoms. Some of those symptoms, the same symptom can be caused by concussion and other things at the same time. You can have things that would ordinarily be considered concussion symptoms that in this person are being caused by something different, a different type of injury, a different type of problem. So we always have to keep thinking. We have to keep looking at the whole picture throughout. We can't just sort of like lump it into concussion and say, all this is from concussion. Just to briefly go through defining concussion, first on a sort of biochemical physiologic basis. So this is, I'm not going to spend too much time on this slide, but nerve cell, the sort of hallmark of the metabolic changes in concussion is there's sort of this excessive depolarization and action potential being propagated. So there's this increased activity, which leads to neurotransmitter release, causing some change in ion movement across membranes. To get back to restoring that normal homeostasis of that membrane, you have to have some energy and to activate some pumps. That energy sort of kicks up the metabolism inside of that cell, so you have an increased energy demand within neurons. And so this is that same information, this is from mouse models, but looking at it sort of over time, and you can see along the bottom that these changes, these kind of, these increases that are happening, tend to be resolving by about 7 to 10 days. So a lot of the information you hear about people saying like concussion typically lasting 7 to 10 days, a lot of that comes from this biochemical understanding. At the same time, there's also changes in blood flow. So these are these are animal models, these are the same animals. This is over time, so this is up to an hour after the actual induced trauma. But you can see this is the percentage of normal blood flow, and you can see that it drops almost about 50%. And so there's a physiologic change in sort of the ability to regulate blood flow to the brain in the acute injury. And so the combination of those two things, this increase in energy demand, along with a concurrent decrease in energy supply, leads to an energy mismatch. And that energy mismatch leads to brain dysfunction, neuronal dysfunction. So concussion is not an injury that is affecting any specific part of the brain. It's not localizable. It's a diffuse problem. It's really a network injury. So our brains work by forming networks normally. In concussion, there's a disruption of that normal network formation. So our brain can't process information as efficiently, can't do things as accurately. And so ways I describe it to patients often is sort of like having slow Wi-Fi or having slow cell phone signal. Another way is traffic. So I grew up in Buffalo, so this on the left side is, kind of rush hour traffic in Buffalo, and this is rush hour traffic around New York, and you can see clearly, the difference. But your brain, when it's concussed, right, looks more like that picture on the right. It looks more like that congested traffic. From a clinical perspective, the common signs and symptoms of concussion, people tend to group them into categories. So there tend to be elements of cognitive and mental status effects. Physical symptoms, those sort of tend to fall into like migraine, vertigo category. Effects on mood, effects on sleep. But really, it's a broad range of possible symptoms. Every person is going to be different coming into the injury. Every person is going to be different, what they're sensitive to, what they're prone to. And also every injury is going to be different. So not everybody's going to have all these symptoms. Not everybody's going to have the same symptoms. But in general, it should be some combination of symptoms, a collection of symptoms that evolves after the injury, suggesting a brain dysfunction is going on. The important thing to keep in mind, though, is figuring out, when you're seeing somebody with concussion, figuring out what's going on with them. It's not just a matter of listing symptoms. It's not just giving them a checklist and having them circle kind of, on a 0 to 6 scale, how they're feeling. You need to know the context. You need to know the specific details. Just knowing that somebody has a headache and they rate it as a 4 doesn't really tell you anything about what that headache could be coming from or what to do about that headache. Asking specific details. So just kind of getting a symptom checklist filled out doesn't give you really any information. That's sort of a starting point to taking a full, like, completed history. Symptom checklists are pretty common. This is a version of a symptom checklist that I like to use. Most of the symptom checklists kind of are 0 to 6, right from not there to mild to moderate to severe. I tend to like to ask on a scale of 0 to 3, really just based on the functional impact that it has. I find that that's a more useful way to sort of anchor it in their effect on functions. So sort of a 0 is it's not there. 1 is it's there, but if you get distracted or you're busy, you don't notice it. 2 is where it's there, it doesn't go away and you notice it, but it doesn't interfere with your activities. And 3 is if it's bad enough, it interferes with activities. Because when people rate 0 to 6, it's a wide range of sort of how they'll view those rankings, what they'll actually consider a 1, a 2, a 3, a 4, a 5, a 6. But if you actually ask them sort of like, does it does it bother you all day? Does it interfere with your activities? It kind of gives them a little bit more of a firm framework to discuss their symptoms in. So it's important to remember that a concussion is a projection. So injury happening to this person's brain could lead to an injury presentation and a recovery that looks like this. If you had that exact same injury to this other person's brain, to a completely different person, they might have an injury that looks like that. Different peak in symptoms, different type of symptoms, different duration of symptoms. So it's something that you have to look at each concussion individually. Every person's going to be different. Every injury is going to be different. You have to look at it as an individualized process each time. That's a problem that's happened with concussions. There's a lot of protocols. There's a lot of sort of guidelines that have sought to sort of make it a formulaic thing where you kind of plug people in and let them go through, and it's the same for everybody. And that just really hasn't and doesn't work for concussion. So when somebody comes in and you're trying to figure out if they're concussed, we should probably be talking about diagnostic certainty in concussion. So it's a clinical diagnosis. It's based on sort of like the mechanism, what happened, and the clinical effect. What kind of symptoms did the person feel? What was the timing? When did they start feeling them? How is it evolving? What are they able to do and not do? What makes it better? What makes it worse? And then their exam, looking at their exam and how that changes over time. And that should be looking at the symptoms and exam and mechanism, not just to figure out, like, does this fit with concussion, but also what other things could it fit with? And I like to, there's different ways to do this, but kind of talking about definite, probable, and possible concussions. It's sort of like how suspicious you are for concussion as the cause of that person's symptoms. So definite concussion would be something where concussion is the most likely and really the only possible explanation based on the mechanism, based on the clinical effect that person's having. It's really the only thing that could explain that person's presentation. A probable concussion is a scenario where concussion is still the most likely cause of that person's symptoms, but there are other things, and that could be other types of injuries, other pre-existing problems that are maybe less likely or similar likelihood to be causing those problems. But concussion is still the most likely diagnosis. And a possible concussion is a scenario where maybe something about the mechanism, it wasn't necessarily a great mechanism for brain injury, or some of the clinical effects or the timing of them don't match up right. You're considering concussion, but there are other possible explanations. There are other things that are more likely and explain that person's presentation better. At the end of the day, whether you call it definite, probable, or possible, what really matters is how you treat it. And so for definite and probable concussions, really those should be treated as concussed. Those are ones where you suspect that concussion is the most likely thing to be causing it. Even if there are other things that are involved, you should still be treating those people as concussed. Possible concussions, though, you can treat those situationally, depending on the level of supervision you're going to have over that person, depending on what resources are available. You can sometimes get away with not treating that person as concussed and treating it for whatever the most likely diagnosis is, while allowing them to continue their activities. Mechanism is a really important part of that. So that mechanism is often given by report, but now there's more and more, even like youth sporting events, patients are coming in with video footage where you can actually let me watch the video. And that really helps, one, to sort of figure out how likely, like what kind of force was involved and how likely is it could have caused a concussion, but also what did that person do immediately after they got hit? Does it look like they lost consciousness? Did they get up right away? How was the balance? And finally, looking for other possible mechanisms of injury. So if you look at the picture in the bottom left, that's somebody who, if you saw this happen, you certainly want to screen for concussion, but that's also one where you want to definitely make sure you screen for cervical issues and neck injuries. It also depends, different sports, different positions, knowing what the risks are for that individual can help you really figure out, it's one of the most important things to figure out how likely it is that person had a brain injury. Because there are a ton of concussion symptom mimics. So this isn't a kind of an exhaustive list, but just some. So neck muscle strain, sprain, post-traumatic headaches, occipital neuralgia or other peripheral nerve injuries, peripheral vestibular problems, anxiety, panic attacks, diaphragmatic spasm, migraine, other headache disorders, dehydration, heat exhaustion, jaw injuries, TMJ injuries, orthostatic hypotension, injuries to the eye, sleep deprivation, deconditioning. It's a ton of things that can kind of cause similar symptoms. A lot of those can happen to athletes just without an injury. A lot of them can happen after a hit. So it's important to keep thinking critically. Even if you suspect concussion, all these things can happen in conjunction with a concussion occurring. And if you take that person and just diagnose them with concussion, some of these you're going to miss out on treating them and addressing them in a timely manner. And it may lead to some issues with prolonged symptoms after the concussion recovers. But this is especially important early on because concussion, we know there's a problem with concussion and misattribution. So this is a paper from all the way back to 1992, but basically in this study, they took a symptom questionnaire. It was about 30 symptoms that they had people rate as a yes or no, just on a sort of binary scale. And they asked about the person's current symptoms and also an estimate of how often they felt that thing prior to their injury. And they did this in 100 people with concussion or mild traumatic brain injury. And then they gave it to 223 people as controls to just say, like, how often do you feel these symptoms? And so this is the results from that. And so you can see first column is going to be frequency and controls. So this is just sort of like all these symptoms going down this table. They ask, how often do you feel these things? Pretty frequently. Some of them, up to a third of them, were saying they would have some of these symptoms that were kind of considered concussion symptoms. And then if you look, they took the 100 concussed or mild traumatic brain injury patients and asked them, prior to your injury, how frequently do you have these things? And the people's estimates are significantly lower. So the ones with the stars next to them are the ones that had statistical significance. For some of these, the difference was pretty significant. A pretty big difference between the sort of frequency that control patients were noting it and the frequency that the concussion group was estimating it, suggests that those people were now attributing, after the concussion or MTBI diagnosis, they were attributing any of those symptoms to the injury and saying kind of like, I never had this before. And that's something I, in practice, see all the time. You ask people, did you ever have headaches before? And they say, no, I never had headaches at all. The likelihood is that some of those people probably were having headaches before. It probably wasn't something that was a frequent problem or caused too much disability or wasn't something they were overly concerned about, but it was probably happening. And now the normal rate of headache they might have been having before is being attributed to an ongoing injury. Similar study about 10 years later in 2002, they did it a little bit of different scale, looked at kind of the same 30 symptoms, but it was ranked 0 to 4. And they asked those people in controls, in people with concussion, and in people with a non-head injury, people with orthopedic injuries. They asked them the same thing on a scale from 0 to 4, how you feel now, and then also an estimate of pre-injury for the injured groups. And so in this table, the normal, this is the controls. On that symptom score from 0 to 4, they were kind of the mean symptom score they were reporting was 37.2. So this is people who had no concussion, no history of concussion at all. So it just points out that those symptoms that we attribute to concussion are commonly occurring in just the general population. In the group with head trauma, they had it 1 week, they asked sort of before head trauma, how often do you have these? And then after the head trauma, how often are you having it now? And then at the 3-month mark, they said, again, before head trauma, how often do you have any of these symptoms? And after head trauma, right now at 3 months, how often? What we see is that their estimate of how they were before the injury is significantly lower symptom score than the control population. But even at 3 months, it went down from where it was at 1 week. So as things got further out from the injury, they remembered even less, that they reported even fewer symptoms prior to injury. And even in the orthopedic group, these people didn't have head trauma at all. They had orthopedic injuries. Their pre-morbid reporting, their pre-injury reporting of their symptoms on that concussion scale was lower than the normal group. So they were only reporting a mean of 27.5 compared to the 37 for the control group. So it suggests that even if it wasn't a concussion, even just any injury, after the injury, people were tending to attribute symptoms to the injury rather than something that they may have had prior. So I think a takeaway here is that after injuries, people tend to underestimate the rate of premorbid symptoms, and they may attribute symptoms to occurrence of the injury. That's really important with concussion, especially in kids, because of the age that people are participating in those sports. From that first slide, the sort of one about the sort of sports career, when in their life that occurs. This is information from the Bureau of Labor Statistics, just looking at the median age of different activities amongst Americans. And kind of if you go, the left, that's sort of like the highest median age. And if you follow it down to the median age teenage years, it's sort of like in order from least impactful, least likely to be injured from a head trauma perspective, all the way down to most likely, right? So things like golfing, walking, aerobics, cardio equipment, yoga, all these things, very low risk of concussion or head injury, tend to be things that people are doing at much older ages. Things like baseball, softball, soccer, basketball, football, way more common happening in teenagers. Some other stats, this is from USA Hockey, the registration. So people registered for USA Hockey, the majority are under age 18. And so, again, really these sort of head injury risky behaviors are commonly happening in younger people. Same for USA Lacrosse. Pro and post-college, very few people are still playing lacrosse, but in high school, youth, and college, that's where really the peak is. Why is that important? Well, age and migraine. So up to 12% of the general population, 10% of school-age children have migraines. So it's a really common thing for people to get migraines. About half of people will have a first migraine episode by the time they're 12. So it's really something that tends to present in younger kids by the time they kind of get to puberty. Most of those people will already have had migraine, but about half won't have. By the age of 40, about 90% of people will have their first episode. They're going to have migraine. And migraine is something that's underdiagnosed. A lot of people go a long time having headaches before they ever get officially diagnosed as having migraine. And so this is something that I find is an attribution problem, misattribution problem all the time, is the common age that people typically start getting migraines and typically they'll start having headaches also overlaps with the common age for kids to be playing sports that put them at risk for head trauma. A lot of times those future migraines get linked back to the concussion, when in reality, that might have been something that happened anyway. It's a really common thing. Looking at age and ADHD, mean age of diagnosis for ADHD is around 7 years of age. But again, a lot of people, it's a delayed diagnosis. In school-age children, it's about 8 to 11% prevalence. In adolescents, it's about 9%. In adults, it's around 4%. So there is a peak typically in school-age and adolescents. And so a lot of times kids are having difficulty in school, having trouble with attention and focus. That could be sort of the normal occurrence of ADHD in that age group rather than a result of ongoing concussion issues. And then finally, age and anxiety and depression. About a third of adolescents, 13 to 18, so high school age kids, about a third of them are affected by anxiety disorders in some way. About a third of adults also experience anxiety disorder at some point in their life. Major depressive episodes happen in about 13% of adolescents in that same age range, and about 7% of adults over 18. So really common for anxiety and other mood disorders to affect kids in that age range. And so these things co-occur in the same time frame that people are at most risk for being diagnosed with concussion. Many of those, I see tons of patients who come in and they're displaying signs of anxiety, depression, potentially having migraine-like headaches or having symptoms of ADHD. I find that they're often not treated adequately if they're attributing it to a concussion. They're sort of, oh, this is a result of the concussion. Reality is most of those people probably would respond to the usual treatments for those underlying disorders, but they haven't been diagnosed officially with those things, so no one's really pushed that for them. So somebody has a concussion, we need to get them back to sort of playing sports, get them back to their normal activities, so the sort of management of concussion. When a concussion is suspected, it's not a question of diagnosing the concussion in that moment. We're not trying to initially say definitely a concussion or not a concussion. It's really a question of, is it safe for them to return to play? The first thing you want to do is remove them immediately. The reason for doing that, number one, it avoids the risk of additional injury. And that's not just another concussion or making the brain injury worse. There's a lot of studies out there now looking at the risk of musculoskeletal injuries, so lower body injuries in concussed athletes who return too soon, or even after, like some studies looking even like weeks and months out. And there's higher rates of musculoskeletal injuries in people who are returning to playing their sport when they're concussed. There's a lot of theory about why that happens, but we know that removal from play can potentially avoid that risk. And there's definitely good evidence that people tend to recover earlier, get back to playing sooner if they're removed right away, as opposed to continuing to play. Important to get an expedited appointment with a concussion specialist. Some of that misattribution can be avoided if you can get in right away to confirm the correct diagnosis or diagnoses and begin appropriate management, not just for concussion, but for any of the other pre-existing or concurrent problems. The initial management of an acute concussion, first is going to be anticipatory guidance. Every person who comes in for a concussion, I want to see them as early as possible, but I really want to talk with them about the usual recovery course and set expectations for them. the biggest change that's happened in recent years is we know now that early mental and physical activity is safe, and it's actually beneficial when people do it properly. Brain rest isn't possible to do. It's not helpful to do either. This could be kind of another hour-long talk to get into, but we have ample evidence now that early exercise, early cognitive activity, early return to those activities actually helps people. Prolonged avoidance of those things tends to lead to slower recoveries and greater levels of morbidity. The other thing you want to do early on is aggressive symptom management. Treating their headaches, working on getting them back on a good sleep schedule, assessing their neck, providing appropriate treatment, working on any cognitive problems, working on some accommodations and modifications to their school day or to people's work day. Assessing for pre-existing comorbidities, prior injuries. So asking, have they had prior concussions? What were their recoveries like? Do they know someone in their family who's had a concussion? What was that recovery like? Because that might frame their expectations for how they're going to recover from this future injury. And we know that that's not necessarily going to be the same. It varies injury to injury and person to person. Looking for whether that person might have pre-existing migraines or ADHD or mood disorders, learning disabilities. Those things are things we can start addressing, but also we can start to discuss how it interplays with the concussion. It may slow down recovery or make symptoms last for longer. And then going into education and talking about their long-term concerns. I like to have that discussion early on. One of the biggest things I've found is that kids, when they're coming in, being seen for concussion, especially athletes, they're sitting in the room talking to me. One of the biggest worries they have is that they're going to be told that they can't go back to playing sports or that they need to retire from their sport. And if they go through the whole visit worrying about that, they're not hearing everything that you're saying. And so I like to talk about that up front, let them know, hey, and I know you might be worried about the long-term implications of this. We're going to talk about all of that. We're going to discuss, the risks and benefits, and we're going to make sure we have a safe plan for you to get back to doing the activities you want to do. So you want to talk about what the long-term risks are, the knowns and unknowns about that. Talk about prevention strategies too. So this initial management is crucial, kind of setting these expectations, giving the person the right information. And the reason that's so important is there's a significant placebo and nocebo effect in concussion. So most people have heard of the placebo effect, so a positive effect produced by the patient's positive expectation and belief regarding the state of their health or response to a treatment. But not as many people might know about the nocebo effect. So nocebo effect is essentially the opposite of the placebo effect. It's basically a negative effect produced by patients' negative expectations and belief regarding the state of their health or response to treatment. This comes into play the most in terms of side effects from medication. So there's a lot of evidence that even if you're giving somebody a medication that has no active ingredient in it, if you tell them that it has significant side effects as a potential for taking it, the majority of those people will report those side effects. So you can have the same sort of like placebo effect can happen in the opposite direction. Don't have time to get too deep into it, but this is a recent review article. This just came out last month in the New England Journal, sort of an overview of placebo and nocebo effects. It's really just fascinating that I recommend if anyone has interest in that at all, reading that is a great starting point. But recently, some information has come out about nocebo effect in concussion. So in clinical concussion care, there's significant chance for nocebo effects. Number one, there's a lot of negative expectations. That person might have negative expectations based on something that a friend or family has experienced, something that they've experienced, something they've seen on TV. There's a lot of potential for misattribution. All things that person experiences that are negative then kind of get like related back to the concussion. There's a lot of societal nocebo, media representation, sort of in the news, but also there have been movies that have come out, public health campaigns, anecdotes from friends, family. There's a lot of negative representations of the outcomes of concussion. And that's been good in terms of the awareness of, and sort of like increasing safety, but it's had an effect of basically everybody has heard the worst possible outcomes, and nobody really hears any of the potential positive outcomes that people can get better, that people can recover. So people come in with very negative expectations, and that can frame how their recovery will proceed. And so there's ways that we can change that. So concussion expectations, we're doing that anticipatory guidance. That's the goal of that. I like to discuss what the expected recovery course is, not just in terms of time, but in terms of the order that it might happen. It's not necessarily going to be consistently better every day. You might have ups and downs. You might do things that make you feel a little worse, and then days that are a little bit better. making sure that person knows not to get too excited when they have a good day and not to get too discouraged when they have a bad day, keeping in mind that there might be some fluctuation based on day-to-day variations and based on the amount of activity they're doing. Avoiding catastrophizing thought processes. A lot of the people I see come in and they already have sort of like a catastrophic thinking about what's going on. I'm never going to get back to normal. I'm never going to feel better. This is the worst thing ever. You want to try to avoid that. Try to talk about the potential for recovery, the likelihood that they're going to recover and resume their activities again. Explaining the underlying injury, talking to them about what is the injury, where does it come from, what causes the symptoms. Try to minimize their fear about symptoms. I ask patients all the time, what's your understanding of where this is coming from? And most of them are sort of like, I don't really know. I guess it's just that my brain is still injured. But there's a lot of things that we understand and that we can explain to them about where symptoms come from, like headache and dizziness. Trying to kind of demystify those things so there's less fear about it. Providing options for the patient-controlled active management of their symptoms. So not just telling them like rest and avoid things and wait, but giving them options for medications, therapies, lifestyle modifications, kind of a real active involved plan, making them feel involved in the process. Offering them close follow-up for any continued or worsening symptoms. So, most of my patients, I like to see them back quickly early on to make sure that things are getting better, to make sure that they're not getting stuck, make sure they're not worsening in any way, so we can come up with a good plan for treating those things. And discussing their goals, what they're worried about, what are their long-term concerns. Start from the outset, talking about all those things. So this is a graph I use for sort of defining the phases of concussion management. So you see this kind of represents the injury with a peak early on and then gradual recovery. This is where the injury resolves. This is sort of the symptom threshold. So everybody will have sort of a threshold of symptoms above which you have to have enough injury that it gets above that point. But we assume that at some point in time, as they're recovering, as the injury gets better, it'll kind of dip back below. And there's this period where they may not be symptomatic at rest or all the time, but the injury may still be recovering. So it's something we have to take into account. The first phase of concussion management is acute rest. That's sort of been the hallmark forever. Is sort of, you need to rest in order for your brain to recover. The thinking on that has changed a lot. The reason for acute rest isn't to allow your brain to heal. It isn't to prevent you from worsening the injury. Really, acute rest is meant to minimize symptoms. So we know that early on activity can increase symptoms, but we know that outside of a repeat injury, outside of getting hit again, it doesn't cause increased injury. It doesn't prolong the injury. So many people don't need this acute rest phase. It's based on whether the person is comfortable doing any activity. The most recent consensus guidelines sort of recommend a period of no more than 24 to 48 hours of acute rest as needed for patient comfort. So within the first couple of days, if the patient is so symptomatic that doing activity causes them a lot of distress, it's reasonable to have them do a lot of resting. Many people don't need that. Many people can sort of start, if their symptoms are improving or resolving a little bit, they can start in the stage that we call relative rest. And relative rest is really any activity that doesn't pose significant head trauma risk. So things like cognitive activities, school, using technology, light physical activities, social interactions, all those things you can gradually resume and continue doing them as tolerated based on comfort. And so people are allowed to be symptomatic in doing those things as long as those symptoms aren't increasing or worsening to the point that it's causing discomfort. The goal of that is to resume your normal routine, get back in your normal activities while the injury is recovering, while the symptoms are resolving. And we should be actively managing the person's symptoms during that time, making sure they're able to tolerate things the best they can. And we're avoiding sports and other activities that might pose head trauma risk to avoid that risk of not just brain injury, but also those musculoskeletal injuries. Finally, the last stage is graduated exertion. And so that's the sort of return to play protocol part of this. So for the most recent consensus guidelines that have come out on concussion, again, this is a process that used to be you had to be completely asymptomatic at rest over here before you could even consider doing this. Now we know that early on, exercise is actually a helpful thing to do, and it's really safe. So really, people can still be symptomatic as long as those symptoms are improving, and as long as that person's getting through their day without any significant limitations. Even if they're symptomatic, it's okay to start exercising. And the goal of this exercise isn't just to sort of like have a set number of steps that everybody does the same things. The goal is to challenge that person's brain with both physical and cognitive activities, doing complex tasks, in order to see when you do those activities, it should lower their symptom threshold and sort of bring out symptoms if they're there, because you want to see, is this person's brain functioning normally right now? And is this person able to tolerate these activities how we'd expect them to, indicating the brain functions normal again, therefore the injury must be resolved. And so in general, there's different ways to sort of label these, but it starts with sort of basic cardio activity. And again, as you're going along, you're kind of having them do these activities to try to lower that threshold and bring out any symptoms. Next is agility, adding more complex exercise. Next would be sport-specific exercise. And then when it's applicable, introducing contact in a controlled way before you kind of clear them. You want to see that they've done everything, tolerated it, and are able to safely return to that sport. A little bit more on that return to play progression. So the cardio exercise, it's really something you should start with light exercise, sort of in steady state, and add in some moderate and high intensity exercises, some intervals. Progressing into adding complex movement, the agility stage is sort of direction changes, rotation, changes in body position, adding in weight training, usually starting with body weight and then building up. The sport part of it, that's when you start adding in individual drills, sports environment, drills with limited risk for contact, adding in more complex environments and more full practice activities as you go along. And then contact, when it's relevant, sort of having a full contact in a controlled setting where the person is expecting it and knows they're doing it with a teammate, with their own team, rather than a game, prior to being in game participation. This shouldn't be something that's the same for everybody. It should be an individualized process. Exercises and activities, they should be relevant for that athlete, for their sport, for their position. I see a lot of people come in who are in a protocol or a return to play progression where they're doing activities, doing exercises they've never done before. It's not possible to really make any judgment off of that if you're having somebody do an exercise they've never done before. Someone who's like a swimmer and they're on a bike. If they've never ridden a bike before, you don't know how they would have normally felt if you did that. So you want to make it individualized to the specific person. And in between, you want to allow enough time after each time you challenge them for seeing if symptoms develop, seeing how they respond so you can evaluate it. This shouldn't be sort of like that's step one, this is step two, this is step three, this is step four. These things can blend a little bit. It's just a matter of the progression, starting with the more basic stuff and gradually increasing. Just one more update, there's all the studies that have been coming out looking at graded exercise programs. A lot of those look at treadmill and bike protocols, but essentially what they're finding is that even from the very beginning, right after concussion, same day and next day, it's safe to have people do light, low impact exercise. And so it's something where we should even be thinking about extending that cardio to be like from the beginning. We should not eliminate cardio exercise, because I think the problem we run into a lot is people who get stuck resting for too long without doing any cardio activity. That can lead to as many problems as the injury itself. People get extremely deconditioned. People develop avoidant patterns, and so the health benefits of ongoing cardio exercise are being shown. All right, so a little bit about post-concussion syndrome. Every once in a while, someone diagnosed with concussion will go on to develop prolonged symptoms. We need to get those people back, recovered from that. So first, just to distinguish concussion versus post-concussion syndrome. So same kind of picture. This is the sort of underlying injury. This is the 7 to 10 day mark. We expect it would recover. And so normally concussion symptoms recover in that same 7 to 10 day periods. Typical concussion symptom recovery will look like that. But every once in a while, somebody will have a different recovery. It takes longer. A common one is things will start to improve and then plateau off. You get this kind of like up and down plateau where it's not really following a direction anymore. There's not really a number of days. It's not like once you're 10 days out or once you're 7 days out. There's no time cutoff for whether you can say it's concussion or post-concussion syndrome. It's really a combination of how long it's been from the injury, but also the pattern, right? Does it seem like things are steadily improving? With concussion, it should be a monophasic injury. If you start to see a plateau and then things worsening and then ups and downs, or if you see somebody's concussed and really like from the beginning it's a plateau, that should make us think from right from that point, hey, there's probably more than concussion happening here. There's something else making these symptoms make these symptoms last or make these symptoms last. To address post-concussion syndrome, it's an active process. You have to take a comprehensive history, really figure out all the elements that might be contributing to what that person's feeling. And you make a list. These are all the things. Unplugged syndrome, that's sort of where people are sort of like not exercising, not connecting with anyone socially, not in school, not on devices in any way. They're sort of completely unplugged from the world. Underlying migraines or other headaches, other headache types, mood issues, difficulties with sleep, neck injuries or neck problems, ADHD, other learning problems. Huge long list. Every single person I've ever seen with post-concussion syndrome has multiple things going on that are all interacting in some way. And it tends to be different for every person. But really, you want to sort of map it out. I draw on a whiteboard during the visit with my patients and try to figure out, kind of exactly when things start, what the pattern is. Another thing I like to do is dynamic evaluation. So, taking them into the environment they're used to being in. So on a turf field, in a gym, on an ice rink, and actually putting them through complex exercises to sort of assess, one, how they respond to it, to sort of try to figure out the likelihood that the concussion is still present, but also to look for other areas of dysfunction to sort of come up with a tailored rehabilitation program. So I wanted to play just a short example of that. This is a professional hockey player who's in the gym with us doing some complex tasks as part of a rehab process. And so starting out, just some sort of basic cardio, some balance-related exercises with some hand-eye coordination. He's a juggler, so we had him do some juggling while balancing on a Bosu ball, stuff that focuses on rotation. We would also call out which way to turn, call out when to turn, do 180s, do 360s. Here he's playing ping pong while he's looking at a screen in the background that's playing a sequence of numbers he has to remember. He's on a electronic surfboard, and also the balls are different colors. We're telling him sometimes to hit only one color ball to one side, the other color the other side. Asking him to count the number of each color ball he's hitting. Having him do complex visual coordination and cognitive tasks while exercising. You can learn a lot from that based on which things are bothering that person, based on how they're able to perform what they had trouble with. One thing that you find is as you make the task more complex, some of the symptoms, when they're distracted, when they're able to actually kind of like do a complex task, they tend to notice it bothers them less. And that can be really helpful for progressing somebody back to their normal activity again. So you have all these things, they tend to overlap and interact with each other. You have them. And with post-concussion syndrome, these things tend to add up to something much greater than what they would ordinarily cause. So this interaction, these sort of like two-way interactions, and this tangled mess, becomes this kind of monster that you really can't penetrate, right? The key is to sort of break it down. Try to separate those things out, make a list, and come up with a plan to treat each one of those things. So this is not really a comprehensive list of the problems that lead to post-concussion syndrome, but there are definite treatment plans that you can come up with that target things like complex syndrome, mood, migraine and headaches, ADHD, sleep, neck. Most of the time, as you start treating one, it tends to have an impact for the other one. So people who aren't sleeping well tend to have problems with their mood. They tend to have problems with their attention. They tend to be more likely to get headaches. So if you improve their sleep, those things improve. But also people who are in a better mood, less stressed, usually sleep easier. When people are less stressed and anxious, they can pay attention better. When people are having trouble with attention, they're having trouble in school or at work, it often makes them more stressed. When you're unplugged and you're not able to do any exercise, you have no outlet for your stress, you don't have any sort of support, you don't have any interactions with people that are sort of necessary. So all these things are interacting. But over time, if you actively manage these things, people will get better. I've seen the majority of people recover completely. All right, so finally, last part I wanted to go through is just sort of overall looking at the long-term brain health part of this. And so when I'm seeing somebody as part of their neuro baseline, I like to talk about long-term brain health concerns. So one thing I'm doing is screening for underlying diagnoses or even tendencies. So things like migraine and learning disabilities, mood disorders, monitoring for chronic symptoms. Are there things that are sort of like happening in the background that are building up that this person's having more of? Monitoring for brain dysfunction. Is there any evidence of changes in neurological exam, changes in their performance in sports, school, and life? Discussing risks and the benefits. So some of the risks we know, some we don't. A lot of the benefits we do know, but I think this conversation often tends to lean towards the risks and not really the benefits. Discussing the annual dose of force. How much contact is that person exposing themselves to? Somebody who's playing football in the fall, then wrestling in the winter, and then lacrosse in the spring is a lot different the amount of force they're experiencing as opposed to somebody who's just playing hockey in the winter. And then also figuring out what's their future exposure is. How long do they plan on playing this sport and at what level? And then re-educating them and planning for the future. The question that always comes up is sort of like, when is it time to retire? When is it too many? There's no number of concussions that's too many. Number 3 has been out there forever. Is once you have 3, that's when you should retire. You have to consider every individual differently, consider the entire patient, all the variables that go into it. You want to look for evidence of brain dysfunction, looking at their exam, looking at their performance. You can get ancillary testing, neuropsych testing, looking at the risk for catastrophic injuries. That often entails looking for anatomical changes that could put them at risk for a higher injury, neck or brain injury. What's their symptom burden? How often are they having symptoms? Are those happening only with injuries? How often are the injuries happening? Are they happening between the injuries too? You have to consider the impact of continuing to play that sport on their overall health, as well as what the impact of removing them from that sport would be. And so this is a study that came out in 2000, looking at sports participation amongst high school students. And so they had a survey of over 14,000 high school students in the US. That was the Youth Risk Behavior Survey. It looked at an association between playing team sports, this was team sports only, not individual sports, and other health-related behaviors. And so about 2/3 of the male students played at least one team sport or more, and about half of the female students. Essentially what they found was that the group, both males and females, the group that was involved in team sports had lower rates of lots of risky behaviors, like smoking, drug use, weapons, suicide, unhealthy diets, not exercising regularly. So the numbers are here. This is for the girls. So this is the team sports participants. This is people who didn't play sports. These odds ratios, so if it's less than 1, it means the sports group was less likely to have that behavior. If it's greater than 1, it's more likely. So they were more likely to have regular vigorous exercise, less likely to not eat fruit, not eat vegetables. So they're more likely to eat fruit and vegetables, less likely to smoke, use marijuana, cocaine, other legal drugs. So a lot of healthy behaviors were associated with that participation in sports. And the same thing for males. You can see the same. Regular vigorous exercise, much more common, and then protective against some of these other risky behaviors. So there's a significant positive impact that if we're sort of not discussing or not taking that into account, we can cause some problems, even if our intention is to sort of help these people. On the risk side, the thing that most people are worried about, and a lot of people will bring up now, is CTE, chronic traumatic encephalopathy. So I just want to briefly go over that, what that is, what it means. So CTE, it's a tau protein deposition, so similar to Alzheimer's disease, but there's several dozen diseases that have tau protein accumulation as part of it. But it's in a specific location. It's sort of at the depth of sulci in the brain around blood vessels. It's presumed to be from repeated head impacts, although we don't really know for sure. It's unclear what the actual risks are for this, and it's actually unknown what, if any, clinical effects that protein accumulating there will have. It's a pathological finding, so it's not something you can diagnose without tissue. So it's only a pathological finding on autopsy. There's something that has been termed traumatic encephalopathy syndrome. That's the clinical presentation of neuropsychiatric symptoms in a living person that's presumed to be caused by trauma. So that's sort of a clinical diagnosis that people will potentially make, but CTE is not something that can be diagnosed in a person who's living. But these are some of the headlines that are sort of out there that people are reading. So this one's from CNN, CTE, 99% of study brains from deceased NFL players. Hits the head, not concussions, cause CTE. Hits the head may result in immediate brain damage. Tackle football before age 12 could result in earlier CTE symptoms, a new study finds. So all these kind of like sensationalized headlines. The reality is that, and this could be another like hour or more discussion, but the science behind CTE is really, really not as mature as it needs to be to make those kind of determinations. So this paper came out in Brain, great review from this past year. Basically, CTE neuropathology, they're finding it in the same underlying pathological findings in people who never had head trauma, never played football. And they're also finding that a lot of the clinical symptoms that are being attributed to CTE are common and probably caused by other things unrelated to that protein accumulation. This is important though, because this just came out this month or last month, but basically preterm CTE diagnosis of professional football players. So they had a survey of about 4,000 football players who were retired. And in that questionnaire, they had questions about health conditions, and they used some instruments to measure depression and cognitive symptoms. Basically, about 3% of the overall group reported that they were diagnosed while they were alive as having CTE. Under 60, it was about 2%. It was closer to 4% if you were over 60 in that group. But when you looked at those people in that study, so just this first set here, this is all those people. So this is the 3,800 that had not been told they had CTE. This is the 108 or so that have been told that they had CTE. The CTE group were more likely to be obese, have sleep apnea, indicators of past or current depression, hypertension, low testosterone, pain medication prescriptions, high cholesterol, and markers of dementia or cognitive impairment. While some of those things you could say maybe it's from the CTE, a lot of those things are common things that occur in the population. But if you're telling a person that it's from a progressive neuropathologic neurodegenerative process, that's going to change the way they think about it. They're not going to think about that as something like, oh, if I, lose weight and get CPAP and find a therapist and lower my blood pressure, I'll be better. They're thinking about this as something that they have no control over. So this is the final thing I want to talk about, just sports concussion and suicide. So this is from the CDC, just suicide trends in the US through 2015. But you can see that basically it broke it down by sort of rural and urban populations, but essentially in all populations in the US, the suicide rate is increasing over the past couple of decades. So the suicide rate is increasing in general. As part of that, they had a task force that sort of had a workshop where they looked at something called suicide contagion. So we know that there's a potential contagion effect of suicide. And so they came up with a national workshop for recommendations on the reporting of suicide. So sort of news coverage, media coverage, and the potential risk for suicide contagion. So one of the statements they made from that was that it should be understood that scientific basis exists for concern that news coverage of suicide can contribute to the causation of suicide. So they had a long list of the potential elements of news coverage that can promote suicide as a contagion. And some of the things they found were likely to promote suicide were presenting simplistic explanations for suicide, repetitive, ongoing, or excessive reporting, sensationalized coverage of suicide, glorifying the person who committed suicide, focusing on the suicide completer's positive characteristics. And so this is something that with CTE especially, it's sort of been framed as this neurodegenerative progressive disease that happens to football players, leads to mental health issues, suicide, and the coverage for it. I mean, outside of even the news coverage, there's sort of essentially a movie was made, a Hollywood movie, that really kind of like presents all of this in a really sensationalized but really over-covered way, an oversimplified way. It makes it seem like, if you ask the average person who's potentially just seen news stories or just seen stuff on ESPN, they're going to think, oh, it's really common, former football players committing suicide at much higher rates. Well, there's a study that came out looking at, it was mostly looking at cardiovascular mortality of football players, but essentially about 3,500 former NFL players who played from the 60s to the late 80s. And it looked at all causes of death. So how many were observed from each thing, and then how many were expected based on the average population. And they came up with a standardized mortality rate. So again, if it's lower than 1, it means the football players were less likely to die of that. If it's greater, it means more likely. But overall, they were dying less. They had lower observed mortality than you would expect. They did have a slightly increased risk of dying from a cause from a disease of the nervous system. And they looked into that in a little bit more depth. And so this is the same group. But essentially, with all neurodegenerative diseases, you could see that it was kind of between 1 and 5. And for ALS, it was between like 1.5 and 8. So there was a higher observed cause of death from neurodegenerative causes in that population, but it wasn't like 99%. It was, kind of a significant difference, but not to the degree that, this was sort of only 2 people had dementia or Alzheimer's, only 6 had ALS, 2 had Parkinson's, of that whole population, 3,500. This is from the same study. That at the bottom of that, though, was intentional self-harm, so suicide as a cause of death. And in that group, only 9 had died from suicide, and expected based on the average population would have been about 22. So it's actually protective from suicide to be a former professional football player. They looked at that same group. The original one was out through 2007. They followed it subsequently up to 2013. So they did an additional 6 years. And still they're finding that the overall mortality is lower in the professional football group than expected. And the suicide as a cause of death is significantly lower than would be expected by about half. Another similar study, this is almost 10,000 players, and this was players who only had 1 year. The prior studies were players who played at least 5 years. This was more inclusive, and also people who played more recently, from like late 80s through the early 2010s, and looked at the same thing.
10 minutes.
The observed, expected, and sort of that standardized mortality rate, and they found similar results. All causes of mortality, they had fewer than expected observed in the former football players. They actually found that there were fewer causes of death from disease of the nervous system, and fewer causes of death related to mental, psychoneurotic personality disorders. And they looked at the exact same metric of intentional self-harm. And again, they found that by about half, they observed fewer suicides than would be expected. But this is really important because, there've definitely been stories out there still of athletes who are struggling. A lot of them have been told that they have CTE, or a lot of them are convinced that they have CTE, that there's no way that they can avoid it. When the reality is they're probably dealing with a lot of other things in addition to effects from their head trauma. And so that overall brain health and mental health needs to be a focus. So I wanted to finish up here to leave time for some questions. And thanks for listening.
Thank you, Dr. McCarthy. We have a couple of questions. The first is that a new guideline that you can resume cognitive activities early on? I've always been told to wait at least a few days, a week, before doing any kind of thinking activities.
Yeah, so the most recent, the consensus group on concussion in sports from Berlin, that sort of acute rest idea, that sort of avoiding activity, they changed it to say, we don't really know what the optimal time for rest is, but likely no more than 24 to 48 hours and may not be necessary for everybody. They don't explicitly say like you should start cognitive activity right away, but I think that's the way I've interpreted it. Many people who I've worked with have interpreted it as the evidence for restricting people's cognitive exertion early on is not, there's no strong evidence that it causes injury, worsens injury, delays recovery. There is some concern that you could have more symptoms. And so I always tend to focus on doing it in a symptom limited way, right? They don't have to be asymptomatic, but they have to be comfortable. They have to be comfortable enough doing those activities and making modifications.
Okay, our next question is, are people who have fatigue as a major symptom after a concussion more likely to develop post-concussive syndrome due to the fatigue interfering with return to physical and social activities that aid in recovery?
Yeah, I think I would say that, that's a great question. Fatigue is almost always one of the things listed as an ongoing symptom, and it's usually a late developing one in people who develop post-concussion syndrome. It's usually not that they're fatigued right away after the injury, but it's something that develops over time. And that's a problem because fatigue is something that can be caused by so many different things. Most of those people have sleep disruptions or are on sort of not their typical sleep pattern. Many of them aren't exercising, and so they're sort of like a little deconditioned, and they've been avoiding things for a while. But that fatigue can be a difficult thing to overcome in terms of, the sort of like active exercise and active rehabilitation is what we should be thinking about that as a treatment for concussion, post-concussion syndrome. So I think that early on, that is a big factor. I end up talking to people extensively about you're not going to be able to tolerate as much as you usually do. Don't be discouraged. The goal is to sort of build up tolerance. This is a rehab process. Don't think about symptoms being provoked as setbacks, but symptoms should be a sign of of sort of a need to further expose yourself and further recondition yourself. And sort of setting those expectations, I think, is important. Letting them know it's normal that you can't tolerate what you used to because you've had this much time off, because you had this injury, because you've had this sleep disruption, because you've had cardio deconditioning. But if you explain it to people and give them reasons for what they're feeling, it tends to help them overcome that.
Very interesting. We have another one. Can your sleep pattern still be negatively affected months after suffering a concussion? Can you also still suffer from headaches time to time months after suffering a concussion?
Yeah, so I would say that the sleep part of it, in the acute concussion process, sleep is often disrupted. People have trouble falling asleep, are more tired, don't get as efficient sleep. So that can be initially from the injury affected. Weeks and months out, people's sleep can still be affected, but usually it's not directly a result of that injury. It's usually related to changes in habits and changes in sort of that person's schedule and routine. A lot of times it's people start napping more during the day, which then pushes their bedtime back further, so they're not sleeping on the same schedule, so their circadian rhythm gets thrown off. If they're not exercising, they're not going to school. Sometimes that leads to them not expending as much energy during the day, so they're not able to sleep as efficiently overnight. And that can promote sort of a longer lasting sleep difficulty. The headache part of it, there are a lot of reasons that people still get headaches. It's probably the most common persisting symptom is headache after concussion. Headache, there are so many different things that influence headaches. And so certainly from a concussion, your sensitivity to getting headaches can remain higher, but it's usually not the only thing. Someone's having concussions in their weeks and months after their actual trauma. It's never just the concussion. At that point, there's always other things that have kind of piled on. And it's usually a multifactorial headache. Sometimes it fits a little bit into tension headaches or migraines or one of the kind of known headache categories. But it's really with those about peeling it back and figuring out what are we missing, what else is here.
All right. Do you think that there are going to be improvements to screening tests such as the IMPACT or SCAT to make them more clinically relevant?
It'd be great if that did happen. I think a lot of places have been moving away a little bit from relying on impact tests or neurocognitive tests in general, only because the more they've been used, it's become clear that it's not just influenced by concussion. It's not a marker of concussion. It's a marker of lots of things, right? If you gave that impact test to somebody who's having a migraine or somebody who didn't sleep the night before or somebody who is really anxious and stressed, test anxiety, their performance on that test is going to be different. I think with any of those tests, things like the SCAT, things like the neurocognitive testing, one thing we can always hope to do is sort of like administer it in a way that collects the most relevant data. So looking at it not as just sort of like, okay, I'm going to put you in the room, you're going to take the test, then you're going to walk away. But thinking about the context that they're taking the test. So a lot of they've started opening up to like at-home baselines where kids are taking it like on a laptop at home, and then they get injured and they're taking the test like with a trainer or with a coach with them in a computer lab in school. It's a completely different setting, completely different expected performance you would see on that. With the SCAT, same thing. When they're kind of, a lot of times the kids filling it out on their own when they kind of do the intake, or it's kind of done quickly in sort of a packet of paper. Then when they get a suspected injury, they're kind of going through it with a trainer present. So something, we can improve is sort of the consistency about how we're administering it. But I think the biggest thing is the way we're interpreting it. It's always going to need to be something. None of these tests are ever going to be perfect. I don't think we're close to having like a true objective marker of concussion that's really going to be clinically useful more than a history and exam will be. But those things can be useful if you're able to incorporate them and interpret them in the context of the overall decision that